I want to welcome everyone back tonight. As you know, Victor and I, Dr. Davila and I, have been doing a series on um, collaborative care with surgeons and anesthesia and hot topics and things that are interesting for you to listen to, techniques, studies, strategies. Tonight, our sponsor is PAJUNK. It's a global company that makes needles, catheters, nerve stimulators, all the kits, and it's kind of organic how this came about, where they wanted to help sponsor these two series. Is Victor and I know that we've been using that needle for a very long time, and I started looking at the package. I said, let me reach out to that company, and sure enough, they wanted to collaborate on here. So one of the biggest perks of using this needle for my career has been to not only educate myself in how to do regional anesthesia easily, is also to teaching other people. And Victor knows this, as teaching residents and colleagues, that the echogenicity of that needle is just a game changer. You either see your needle or you don't. And Dr. Cohen, you know this as well, is if you have a successful block or not, it all depends on how quickly and how easily you can see your needle. So there are echogenic tips, reflectors on all these needles. So I want to thank them for sponsoring tonight. I want to thank them for their innovations and their work that they put into the sciences. I want to start also by introducing Dr. Brian Cohen. He is an orthopedic surgeon here in Central Ohio. His focus is everything, in fact. So total knees, hips, sports, ACLs, shoulders. There's really nothing he doesn't do. So Brian, thank you for joining us today.
Appreciate it.
Yeah, we wanted to have an opportunity to talk to you about, regional anesthesia, today at least in focus of lower extremity, and how your career has been shaped by it, changes that we've noticed in that field, and Victor and I can speak to that. But do you want to start by telling us kind of how things have evolved for you for the past, since training, I guess?
Yeah, I mean, geez, I did my orthopedic residency at Mount Sinai. I finished in 1994 was med school, so 99 I finished my residency.
Mm-hmm.
And I mean, it's night and day. I mean, back then people would stay after a total knee or total hip in the hospital minimum of a week.
Yeah.
So I don't really know. We didn't really focus much on what the anesthesia was that they were getting at the time, because they were in the hospital. It didn't matter. They weren't going home.
Right.
We weren't worried about them having a block that may affect their motor function, and that they could fall. These people laid in bed for the first 24 hours. I mean, it just has not, you wouldn't recognize medicine where we started, where we are today. And it's only been, 20 something years. So it's not like it's, 40 years. It's really a snapshot of time.
Yeah.
But back then, I think the biggest thing with regional anesthesia, I mean, I think we tried to push the spinals, and back then we were doing epidurals, indwelling catheters, where patients would get a continuous bump in their epidural medication for pain control. I mean, we didn't talk about narcotic use. How much were they using? How much were they not using? There was no such thing as a multimodal approach to pain control.
Right.
So it's, back then it was really just, you do the procedure and, in 10 days, the patient goes home. It's, and they're almost recovered.
And, I wonder, there's, three things that come to mind right now. It's, back then the insurance concept was different, right? It was all covered. The second thing was the epidemic, the opioid epidemic wasn't high on our radar.
Correct.
Right? The multimodal wasn't. Why do we care about multimodal? And to the other point, the society culture was, I'm gonna get my knee replaced. I'm gonna live in the hospital for 4 or 5 days. And actually, when I first started training, it was almost like desired that patients wanted to be in the hospital for 4 days. We did a femoral nerve catheter. They weren't going to move their leg for 3 days. They're barely going to get out into a chair day one. They're barely going to get up to the bathroom day two. So it was almost the expectation that, from patients, families, it's just completely, for several reasons, whether it's cost from financial or for insurance, the opioid epidemic has really, I think, put a real big change for us on that.
And it should. I mean, if you could just imagine how we do it today and how we did it then, how I don't want to call it malpractice, but how wrong it was.
Sure.
Just loading these people up on narcotics, and just letting them lay, I mean, it was nice for them. They got to see that, they got to see their surgeon or a member from the operative team
Right.
every day for, like you said, 5 days to 10 days. It just
Right.
depended.
Right.
I mean, length of stay was not even something that we even quantified.
Yeah, it wasn't even a metric. Now it's probably the only metric that I care about. It's
Well,
like,
and now it's not even a metric anymore with outpatient,
right, right.
so.
There's a large movement. And I think, regional anesthesia has done wonders to change that. Now we're just keeping up. Now every few years we're really reinventing it. First it was the femoral nerve blocks and the catheters, then the single shots, and then now really new techniques of single shots. And so find that best sweet spot, whether it's a general or spinal or a block or catheter. So there's a lot of, iterations to what we've done. Victor, you feel the same way throughout your training?
Yeah, it's changed quite a bit. I mean, like, when I was in training, the femoral nerve block, right? That was what we did for these, and and it's changing pretty quickly. Now it's the adductor canal and then the iPACK and with or without other stuff, and then there's the catheters, of course. But now there's the other players in the game like Exparel and some of the other stuff that's happening, where like the technology is actually developing so quickly because there's such a demand for it, because of what Brian was saying, where we're trying to get these patients up and about and moving, et cetera. And there's a huge amount of demand for really finding those best technologies to get people moving, to get the pain control without losing the motor block, which is always the real key to all of this.
Yeah.
And that's what's really, it's kind of, the technology keeps changing. So what we're saying right now, what we say today, look at us in 2 years and we'll be saying, oh yeah, man, like that's old news. We got new stuff. And that's, that's where we're constant. It really does require constant updating and constantly looking. You have to actively be looking for the newer thing.
Yeah.
And you never want to be an early adopter, right? But you don't want to be a late adopter either. So you want to be kind of on the cut, you want to be there constantly monitoring what the changes are, because it's easy to fall behind.
Yeah, the gold standard was the femoral nerve block. I mean, because it worked. Patients had zero pain for many days. We blocked every nerve you could, but the downside was that they were falling, and they weren't able to get up and do rehab. And so there were delays there. But
even with those delays, though, they were still doing better than they were before with what Brian was talking about. They were still like, these are patients that were doing well with their pain control, but they were still doing. The reason that became so popular is because even though now we consider it kind of, I'm not going to say the word barbaric, but we consider it like it's an old technique, right? Well, even that was a big jump over what was available before, which was just give them a wad of pills and hope for the best.
Right. And the efficiencies with the blocks has changed so much where, there were times where I had to plan for 20 minutes plus to get a catheter done because it was a whole thing. It was a whole hoopla. The kits were more complex. You had to put the catheter in the right spot. You had to test it. Now there are really new, techniques, and there's equipment. PAJUNK actually makes one where you place the needle where you want it, and the catheter just stays right over the needle. So there are newer, products out there that are making it easier for us to be efficient. Because the name of the game today is efficiency and turnover.
Oh yeah, and what's old is new again. Because for a while there, for example, we got away from nerve stimulators. Because hey, we got an ultrasound, we can see where it's going.
Yeah.
And to your point about the catheter being placed properly, exactly where you want it, that's really important too. Especially, for example, for an adductor canal where you needed to actually have the holes on both sides of that fascial plane, so you can kind of get both nerves. And then you also want to use a nerve stimulator. What's old is new again. Because if you start skewering that nerve, there can be some complications. Nobody's really proven that they're there, but there's definitely, it's the kind of thing where I suspect in a few years we'll know that this is a problem.
Well, I think we're also training a lot of people, not just colleagues, but there are also nurse anesthetists, residents. You're training a higher volume of people to do that type of block than I think we were training back then. It was probably just residents only that we were training. Now, the reality is that there are nurse anesthetists doing practice that it's necessary essentially for us to have the same quality of healthcare across the entire country at all the places that are doing total joint replacements, for really everyone to be doing everything. But, Brian, tell me about your experience with we'll go with each subtype of procedure. what's your flow for total knees?
Total knees right now, our patients are, if they are candidates for spinals, that's our preference. So we'd like them to have a spinal. They get an adductor canal block, and they get an iPACK as well.
Okay.
So, we're trying to hit the front, the back, and then obviously, keep their blood pressure in a good position, blood loss, and all those benefits from the spinal. And then, it's funny because, usually we would inject something in the capsule, but after you guys do all those things, there's not much left, not much medication left that I get 2 cc's to sprinkle in the wound.
Right.
So
well, I was going to ask you. Yeah, I was going to ask you, before we started doing iPACKs, which it's not universally done. I know it's probably the newest trend and probably the expectation for us to adopt that one. But when it was just spinal and adductor, you were missing that posterior part. So you were also supplementing there.
Yeah, I would supplement there. And, at one hospital I work at, we do the iPACK. At the other hospital, we don't do the iPACK. So in the one hospital, it's weird because in one hospital, I'm injecting the capsule. And then in the other hospital, I'm wondering where my injection is. And then it's like, well, you've reached your limit,
Okay. Well, you know what?
I can't sit here and say that I could, I haven't done a critical analysis to say that one's better than the other.
Okay.
But I think it's, one of the keys to this discussion is just having communication, an open communication between the surgeon and the anesthesia provider.
Yeah.
Not only for, what are we doing, but what are you seeing in the post-op so that I could, so that you understand what, what's going on with the patients. And then also, how do you keep that flow? Like you said, it really has to be efficient. So, when is it the right time to do the nerve block? For me, it may be, 15 minutes after I'm in the room. For somebody else, maybe 5 minutes after they're in the room. So it's really, it's not one size fits all. It's really adapting to the surgeons you're working with and kind of getting a flow. And, what happens is that the surgeons rotate through hospitals, the anesthesia providers rotate through hospitals, and there's never that consistency. So that's why these ASCs are so much more efficient, because it's the same people every time.
Right. One of the things that Victor and I have been trying to work on through here is kind of knocking down barriers to that efficient flow. What would you think, if you had to identify one, the difference between those two facilities were one place that they do iPACKs and one they don't? Would you be able to identify a barrier to the one that doesn't? Or is it just cultural there, or what they've been doing? Or
I would say it's two different anesthesia groups.
Okay.
So it's probably what they prefer, through what they do. Okay. I'll ask the question. I'll bring it back to you.
Sure.
Yeah. I was going to say something to consider, because I just want to, before we get too far off this, something that Brian was talking about is like he runs out of a local anesthetic.
Yeah.
That's something you can actually negotiate, because I mean, it sounds funny, but it's true, like those higher concentrations of ropivacaine, for example, that 0.2, which is, it's really how much ropivacaine you're actually giving. Those are really more necessary for the thicker nerves. But when you're getting into the iPACKs and some of those, where all you're trying to get are these kind of terminal nerve endings and stuff, you can get away with lower concentrations and still kind of hit those. And so if you kind of negotiate, what do we want our total dose to be? How much do I want to take, and how much can I use over? And you can kind of divvy it up and plan ahead, and you can end up with it, with a little, you can kind of not have somebody blow your entire budget on what they're doing, and it leaves you a little bit of a budget, for later on in the procedure if that's beneficial.
And I'm sure there is definite benefit to direct injection into the capsule from intra-articular, as opposed to trying to get into this plane between, in the back of the knee.
Right. And I wonder back, when those weight-based restrictions came out, Victor, this many milligrams per this patient size for Marcaine, ropivacaine, was that a time when everything was done really without ultrasound technique, without, maybe with nerve stimulus, so you're kind of blindly going in? Is there wiggle room to say, yeah, this is kind of getting close to the max dose, but I'm kind of watching exactly where it's going. It's not a high area.
So yes and no, right? You always want to be careful, because you never know, right? And the way you arrest from these things is not like, oh, they're getting sick, let's do something about it. They just, boom, they're dead, right? And you're now you're behind the you're behind the gun. But I will say that what is true is that you don't necessarily need to use as much. In other words, you don't have to put in as much around that nerve because you're seeing exactly where it is. You know, once the nerve is floating local anesthetic, you know, you don't have to like, you know, create this enormous pocket around it. Like, you know, it'll, you know, if it's the right concentration floating around the nerve, it will get to where you want to get to. You know, more is not necessarily better. And like I said, it has, you know, you should give the full amount, you know, but like I said, it is reasonable and useful to budget. You know, like I said, it's just like you have a budget. Like, you know, you can blow your wad on, like, you know, it's like, hey, I'm going to blow my wad on a car. He's like, but now I can't buy food for the rest of the day. You know, so I mean, it's just like when you're in college, right? You got to like sort things out and say, I'm going to use this much local for this much local for that, and then, you know, and then leave some extra for the intracapsular injection that the surgeon wants to do. And you know, just really work. That's really important because we can't do that, right? As anesthesiologists, I'm not going to go in, you know, and do that injection at the end, but it's about working together to get the best result for the patient. So actually, it's something that like a lot of anesthesiologists don't think about, which I think they should. You know, they should think about like, hey, how much of my budget how much of the local anesthetic budget am I leaving to the surgeon for the end of the technique? That's a really important thing that we don't think about very often, but that we should be thinking about. And like, we should be thinking about like, is it 0.2? Is it because it's a pain in the ass to drop 0.1 or to drop some saline and like dilute it out for like something that doesn't need that kind of concentration? Because I mean, there's solid evidence, for example, that genicular blocks, or not solid, there's some good evidence that genicular blocks, those blocks that we go around afterwards, are really quite helpful. They have like significant decreases in opioid requirements. But if you already, like I said, if you already gave it all in your iPACK and your abductor canal, well, you can't do it. You know, so
now, are you doing that block, or is that a like radio frequency block in the office?
Are you talking to me?
Yeah.
No. This is like we don't do them. But there's data that because for the same reason, like they use all this local and like the adductor canal or like the iPACK or these other things, but these genicular blocks, like there's some evidence that they can actually be beneficial.
Okay.
Because again, they're getting those little nerve and it doesn't take a lot. It's like you could get the whole knee, you know, with just like 10 cc's of, you know, these are little nerves you're just trying to knock out. And it can be beneficial, right? And that's actually where the debate is now. The newer research, if you look at it, has all to do with like how little can you get away with, so you can kind of start knocking out different things as opposed to like
I've heard about radio frequency blocks for those geniculars, and that's
and cold blocks. They also have the cold ones, the freezing.
Do you do any of that, Brian? What are your thoughts on that?
You know, the problem, well, our interventional pain doctors will do the genicular blocks. The cold therapy, some of our sports, you know, our non-operative sports docs would do it. It's just the cost, you know, there is a cost to it. And anything with a cost is hard to get into a, you know, when you're employed, you don't really have the say so. It has to go through a whole bunch of stuff. So I have one patient that we kind of did we froze the nerves, and it was a post-op revision that just was constant pain and had a great result. You know, obviously it only lasts for about 3 months though, because the nerves regenerate and stuff. So.
Sure.
That's kind of what you want, right? I mean, you don't want them forever, do you?
Right.
Well, if it leaves pain, if I get rid of pain forever, I'll take it.
It's not a motor nerve, so you don't truly need it. What's your flow in terms of spinal? So you come in the day, you've got several patients, you've got several rooms. You let them know when to start the spinal for the next one, so you get the case. We'll
send them back with enough time while we're you know, putting implants in and stuff like that for them to get the patient positioned and put the spinal in. You know, it's one of those things where, you know, you can call out the same, you know, with enough time every time, and obviously whatever's going on out there, you don't know. The patient, you know, went up to go to the bathroom, or, you know, there's a lot of other things that you got to prepare for that you just can't.
Right.
So,
but there's communication between you and the team.
Exactly.
Hey, this might be a difficult spinal. Give me an extra 5 minutes heads up. Or
do they put morphine in your spinals, Brian? Do you know?
They do not. They do not. Just because, you know, our goal is to get these patients home, and we don't want them to have that lingering effect.
Right. And I don't think technically they can go home, Victor, because that 18-hour nadir, there's that re-spike of morphine, that re-metabolism or metabolite that's released. So that's probably why I think a lot of people have gotten away from it, unless you know of others that are still doing it.
I mean, the doses that you're giving are pretty small. You know, and you can get away, I think, with I think it's 115 milligrams. I think we don't do them anymore.
Yeah.
But I was curious. The biggest question I had is, like, you know, because the itching and the I think the bigger issues the bigger issues that I've kind of seen are the fact that you end up with itching, and they also tend to have more urinary retention. I was going to ask if you'd had any experience with that kind of stuff, but you know, but anyway, that was really where that question was going towards.
Yeah,
Yeah,
I mean, a long time.
Yeah, we have obviously urinary retention after, you know, in some patients after spinals without the morphine.
Yeah, obviously,
yeah, it's one of those catch-22s. You know, you want to get them up and going, and then you also have to be aware that you don't want to send them home and have other issues and get readmitted.
And no Foley's on any of your patients, right?
No Foley's.
Right. So there's a lot that goes into, you know, there's so many micro thoughts you have to go through. Okay, make sure they void before taking them back, so that I can still hydrate them if I want to intra-op, and I don't have to worry about having a straight cath on post-op or all those things. But that kind of goes to the efficiency of outpatient surgery and the model that generally the country is going towards. You know, I work in an inpatient facility, but 90% of the cases we do, they're all going home the same day. It just happens that they're operating here.
Right. Yeah. Same situation. You know, going back to, you know, early in the career, everybody got a Foley. You know, back in, you know, the late 90s, early 2000s, everybody got a Foley.
Mm-hmm. Right.
Yeah.
Well, because
if they're going home if they're going home the same day, you're not going to put in a Foley.
Right.
Yep.
The other thing is that the other thing I'd like to mention, by the way, is that you can get, like, with these new nerve block techniques, the right anesthetics on the right patients, you can actually get away without a spinal and have exactly the same outcomes. Like, it's not, that's something that kind of happened, is that, you know, because it was, you know, we kind of had that movement. The evidence isn't really all there, like, you know, especially with the urinary retention, some of these other issues run into, it's not 100%. There, you know, it's debatable. Let me put it that way. It's, you know, you can get away with a general and still get them out the door well.
Oh, sure.
You know,
yeah, absolutely. Yeah, there was a time when we were doing a spinal and a general. Mostly the general is just to keep them comfortable, to not have to give them any sedation or propofol to keep them asleep. But yeah, we were doing a spinal general and an adductor block, and that was it, and it worked. And the surgeon would inject the capsule afterwards. So there's just so many combinations of things you could do. You have to find the right one that the surgeon is comfortable with. But I don't think it would be, you would have to have a spinal or a general. You couldn't get away with just an adductor block and the iPACK. That's obviously not enough.
That's not a surgical block. I'm just saying it's that you can get away with the general without a spinal and still have a really good outcome.
Right. Do you either of you have any experience with adductor canals? Would you ever do a catheter? I mean, adductor canal catheter for any procedures?
I don't have any experience with them. You know, I guess I don't see the benefit of having you know, I don't feel comfortable sending patients home with anything indwelling.
Sure.
So, I think that's.
There was a time when we, not lower extremity, but certainly upper extremity, for shoulders and reverse totals and rotator cuffs, we were doing catheters, and they worked very well. There were some downsides where the patients were calling with complaints with leaking and, you know, potential issues. You know, the catheter migrated. Is it working? Is it still in the right spot? So we've moved a little bit away from that, with the single shots being, you know, really adequate enough. With the multimodal approach we take, you know, most of our patients get PO meds pre-op. Do you have a concoction that your facilities use pre-op?
They get an anti-inflammatory, so Celebrex, or, you know, sometimes they get a Mobic. They'll get gabapentin. So yeah, there's some cocktail out there that changes.
Yeah, I think we have Tylenol, Lyrica or Neurontin, Celebrex, and that's really what we stick to, and that's pretty well. And actually, we schedule the Tylenol afterwards as well. So
yeah, I was going to ask about that. Do you schedule, Brian? Do you tell them to start taking their meds before they feel any pain? You know, just take this. You know, that's key.
That's a big educator. You know, because usually the block wears off at 3 a.m. regardless of when it's supposed to.
Yes.
So yeah, you try to do that, and you know, you know, if it's young patients, you know, because we do some, you know, teenagers, high school athletes. You know, trying to educate the parents, you know, because obviously they're concerned about the opioid intake, and you try to educate them that, okay, look, we really need to get ahead of this so that we don't fall behind, because if we fall behind, you're going to be using a lot more narcotic and other medications. And then also trying to educate them on, we like to hit from different approaches, an anti-inflammatory, a narcotic, maybe a muscle relaxer, maybe a neuro, like a gabapentin or a Lyrica.
Well, one of the companies I've spoken to a couple of different vendors, and they're always wondering, why is it that there's this knowledge about how good our multimodal approaches, whether it's the ERAS protocols or what we're talking about tonight, yet the adoption of that is still lagging behind from a data perspective. So they looked at the data and said, okay, everyone knows this, it's widely accepted, spinals, blocks, outpatient surgery. But the problem is that these facilities aren't adopting it quite as much as we would think. And I think one of the issues I have found, it's even happening here a few weeks ago, is the surgeons groups are finding that we do the blocks, they're so successful, but there's a limit to it. So just like you said, that block wears off at 18 hours or 20 hours, and they're not prepared for what to do next. And I'm not sure if we're not preparing the patient, the nurses aren't preparing the patient, or the offices aren't, but you have to somehow anticipate that this numbness will go away. You need to be very prepared that when your pain score hits a 4 or a 5, take that pill, or take your Tylenol scheduled, so that it's not as profound. And so that phone call that surgeon's group or that mid-level provider from that surgeon's group is getting is generating a complaint, to the point where we're having conversations where, we'd rather you guys not even do the block at all, so that we're not getting a call in the middle of the night that the block wore off.
Right. Yeah. I mean, look, I'm very, first of all, I take my own call, so I'm the one who gets that call at 3 a.m.
Yeah. Okay.
And I'm very responsive to this, and so I'm very educated. I always tell the family, this is what you got to watch out for, because and the way it was explained to me, and I've had blocks before, is that it's like a light switch. It's not a dimmer switch. It doesn't slowly wear off. It just stops.
Right.
And that's what they experience. So I tell them that when they get home, start their medication as prescribed, and then once you start to feel the pain, then you can titrate your medication to what you think you need.
Okay.
But do not try to go cold turkey till you start to feel something, because then you're really behind.
It's interesting that we don't have an algorithm for that. Victor, you and I, we don't have our societies don't come up with an algorithm that says, okay, you got a single shot adductor, that will wear off in most likely this number of hours. If you're prescribed this, take that. Don't wait for this. And so there's such a huge lag, I think, between what we do and what they experience at home, that there's probably room for us to close that gap. And it's kind of
hard. It's hard because, let's say you put in a catheter and you're controlling that pain longer, which there's pros and cons to catheters, right? Those patients have to come back if the catheter is pulled. There's a lot more health literacy that's required for patients that are going to have catheters, all these things. But even if that's working, assuming that, you're still going to have posterior knee pain when that iPACK wears off, or it's always going to be it's always going to be a challenge that we have to look for, right, in terms of what are we going to do for these patients going forward. And you have to be really clear with the patients, by far the worst pain you're going to feel is going to be in the first few hours after surgery, right? And we're going to help you get over that hump.
Right.
But it's I think it's always it's also important to the patient that we explain to them that this is it's a big surgery on your knee. It's going to be quite painful, and that we're going to do the best we can to make sure that everything's under control, but also set the right kind of level of expectations. That this isn't this is not a pain-free environment. This is this is going to be a tolerable environment,
right.
Which is a really, it sounds funny to say that way, but you understand that for us, it's we just slice through your femur. Of course, right. This is going to hurt, right? It's this is, but for the patients, they don't understand that. They just know that there's a little suture going down the side of my knee, and that's all. You know what I mean? So that's.
And I want to think that we do a good enough job at educating them, but I can probably own that we probably are not still doing as good as we can to educate them about what's going to wear off and when, and how directive we need to be. So I think that's probably one of the messages that we'd like to give our viewers, and myself really, is there is probably a lot of room for us to improve our communication. Now, Brian, you take all your calls, so you're able to guide them through that. Victor and I aren't able to help them through that moment because we're not getting the call.
Right. And those patients who have a spinal, they wake up in no pain.
It's those guys.
And I go see them in the recovery room, they're doing fine. I go see them, before either they leave or I leave, and it's the end of the world, and it's like, and so a lot of the stuff, a lot of what you're saying really needs to start in the hospital, because these people don't leave 30 minutes after their procedure. The spinal has to wear off that, so it's really starting, there probably should be some scheduled medications. They don't have to be narcotic. They could be anti-inflammatories and stuff like that, to at least limit the impact when it does, So, I do think that the way we're trained, the nurses and the recovery room staff, they're trained to wait for the patient to ask for something.
Right.
Because they'll keep asking, how's your pain? How's your pain? I feel great. Can you move your toes? I can't move anything yet. And now I can move my toes. How's your pain? Well, I'm still feel great. And then all of a sudden I'm moving my toes and now I can't, I'm in excruciating pain.
Right.
Now that you mentioned it, I actually want to bring this up because this is a debate we had with Hef before and et cetera. Like, so, with the Celebrex and the bleeding and all these other kinds of things, the knee is just as prone or maybe more prone to like these bleeding and these kind of issues. So have you noticed is there like a downside bleeding wise or otherwise to these NSAIDs? Because I'm a big proponent of them, but at the same time, the surgeons will kind of snap back correctly. Like, you're not the one that's having to take them back, because they have some sort of bleed. So have you had any negative experiences that way? I'm curious about this.
I haven't, and I recently, opened up a discussion about using tourniquets and stuff. I had a patient who we did a medial patellofemoral ligament reconstruction, had a block, and then when I saw her in the office, probably a couple weeks later, she probably saw my PA first and then saw me after. She had massive atrophy of her quad, and I was like, well, our surgical field is so distal, so there's no way we could bag the femoral nerve. I knew she had a block, so I assumed it was related to her femoral block. I don't, so then, she had to come back in for a manipulation procedure, which she didn't need because she was moving freely, but we didn't know that because we couldn't move her in the office until we put her to sleep. But when she was talking to a different anesthesia group, they said, oh, you had an adductor block, so it must be the tourniquet. Well, I don't use tourniquets. So it's
it wasn't. They bagged the NVM. What they probably did is they bagged the vastus medialis nerve. So what happened is that they probably used an ultrasound and did not they did not use a nerve stimulator. And so it's really easy to go straight through that nerve. And there have been some case reports where you can actually see the atrophy of the vastus medialis relative to the other leg. And nobody's proven it yet because who knows, right? But to me it makes sense, right? If you're going right there and you skewer that nerve and infiltrate it directly with local, right? It totally makes sense to me that you could bag that nerve and cause an atrophy of the vastus medialis. That does not sound odd. That does not sound odd to me at all.
Yeah, the point of the conversation was going back to the original question about bleeding. So I don't use tourniquets. I don't use tourniquets on total knees. And, we did 3 in one day the other day, and all the blood loss was under, 70, and obviously, with the tourniquet, some people will close with the tourniquet up and some people will let the tourniquet down, try to get all the bleeders. Right. We don't have a tourniquet, so we're getting all the bleeders as they arise. Right. So I wouldn't expect any additional significant blood loss in that situation when I'm not using a tourniquet. But to your question, I don't get too concerned about bleeding from either a low dose aspirin or, an anti-inflammatory. Obviously, Coumadin, Eliquis, Lovenox, that concerns me. But those other medications don't concern me as major concerns for blood loss.
Would you almost go to the point where you would schedule it for 1 to 2 to 3 days post-op, take this every at X number of hours? Would you do that? You haven't found the need to do that yet?
Well, if a patient says to me, look, I need something for pain, they stop my meloxicam, for, a week before my surgery, I say, I just tell them take their meloxicam.
Right.
I'm not going to put them on a narcotic.
Sure. No, of course.
I'd rather them stay on an anti-inflammatory. I'll deal with whatever I have to deal with, but it's never something that is significant in my mind.
Right. Okay.
Or that I look back and I say, why did I do that? Now they're bleeding all over the place.
Right.
How about bone healing? Because that's the other thing I hear about a lot.
Yeah, I'm not going to say it's not. I think it's debatable in the literature. It definitely has swung both ends of the pendulum. You can't use it, and a lot of people still use it. So, I'm of the firm belief if you have good, if you're treating a fracture, you have good fixation, and well adapted bone ends. I don't personally feel like an anti-inflammatory that's going to help them recover is going to affect their bone healing. Now if you have an unstable fixation and you really need other things to come into line, it's not going to heal anyway.
Okay. So if we want to shift gears here now to hips, what unless there's something more of these, we can always come back to it. But what are differences for hips for you? The flow, blocks, all that stuff for you?
I mean, right now, the only thing that we do for hips are spinals. We don't do any blocks.
So no fascial no pain, nothing like that?
No. No, and I don't do any injection. I mean, and everybody will say the hips do better than these.
Yeah, I know. Yeah. There was many years where we did some fascial in residency, but then there's a 5 or 6 year gap where we did no blocks and just did spinals. For some reason, the elderly population, they just tend to do all right on hips. I don't know why. They just like you're saying, they just do fine. But there are fascial that are pretty straightforward blocks we could do. I think the Peng block has become more popular. Victor, do you guys do either of those?
So the one that I would advocate for more is the Peng, because I think that one of the reasons people stay away from the fascial is some of the motor block that you get from it.
Right.
Whereas like the Peng is like those are the little fibers that are kind of, again, the more sensory fibers right around, and I think that you can get some benefit from the Peng block. Mm-hmm. It's becoming more and more in favor, and plus it's easier to do, right? Because you're not trying to dissect, you're not trying to zipper away fascias or anything. You just go right to the, you're going to a bony, you're going to bone essentially, coming back a little bit, and then just kind of taking out that right around that tendon.
What's your pain management protocol for post-op hips then, once they're discharged?
No, I mean it's not significant. I'm just saying this is what I would advocate for. This is what I've seen them. I don't do that many hips personally,
right?
But this is essentially what the literature would support and what people are advocating for right now.
Okay, Dr. Cohen, what do you think? What's your post-op pain protocol post-op?
Still a multimodal approach.
Yep.
So I send it home with a narcotic. I send it home with an anti-inflammatory. I send it home with either gabapentin or Lyrica, and I send it home with Flexeril. And I tell them, do not take them all at once.
Yeah.
It's like you got 4 medicines, spread them out. So you take in something every 2 hours or something, just to keep the flow.
Do you have
you have to be that specific because
I know. I know. You really have to you almost have to write it down sometimes. Do you have like a pill limits for each of those? Or you give them like a 4-day supply, a 5-day supply?
I'll give a 5-day supply, and it's obviously it's evolved over the years. I remember 15 years ago we were writing 40 Vicodin for a knee scope. Mm-hmm. Now I give 9.
Yeah.
I mean, one procedure I did have was a knee scope, and I took Tylenol and Motrin. I didn't take any narcotic. So it's hard. I know people are going to have pain, and people have different pain thresholds, and I don't consider myself having a high pain tolerance. I just decided mentally that I just didn't want to be on narcotics.
Right.
It's hard to operate the next day, after surgery when you have, so.
Well, I think it's all about your mind.
Did you operate the next day?
I operated the Monday. I had surgery Friday.
But
that's going to be rugged.
You do have to prepare your mind for it, right? So the patients that are most well set up mentally seem to do the best. Those that come in with the expectation that your pain will be a 0 out of 10, they tend to do the worst, even if they're at a 4 out of 10.
Correct.
So it's a lot of coaching. There's a lot of work outside of what you and I do in the OR that really does impact their care. A lot of post-op education, pre-op education. So as far as because I know, the pain pills has become the opioid epidemic has really impacted that too. What have you noticed in terms of like hip fractures that are different for you outside of totals?
I mean, with hip fractures, we treat them the same as we do. They get a spinal if they can tolerate it. That's the big thing. Is like, what
Yeah,
can they tolerate?
right.
If they can tolerate a spinal, we definitely want a spinal. But obviously, some of these people are in so much pain that you can't. So we just put them to sleep on the bed, obviously.
Yeah.
But it's still the same approach on the pain side. Hit
Yeah.
them with a bunch of different medications from different, try to get different receptors.
Okay. So outside the ACLs, are you doing ACLs? What else are you sports related working on in lower extremities?
So I do ACL, PCL, knee, regular meniscectomies. I do, open graft procedures, for cartilage procedures, Patel fractures, so, in the nice thing about, well, not the nice thing, but, when we're doing some of these procedures, whether it's an ACL or PCL, or it's a Patel fracture, we put these people in a brace and immobilize them. So for those people, we hit them with a straightforward femoral block.
Yeah, I was just going to say that the nice thing about those is they're not getting up and walking the first day. So, and they tend to do the best because they get what I feel is the gold standard is the femoral nerve block.
Yeah, the one challenging thing is when we do hamstring ACLs is that posterior aspect of their thigh where we basically strip the graft for is very painful, and our anesthesia team hasn't really figured out a great way to get that, because I mean, you got to remember the incision starts at the knee, but the end of the tendon stripper ends up 2/3 up the thigh.
You could, I mean, there is a sciatic nerve block, but it's a
yeah. No, I know there is a sciatic nerve block. I don't know how many people are comfortable or versed.
But this one's different than the traditional one, right? This one's a subgluteal one, obviously. So, and we don't do the subgluteal sciatic block very often. So it's probably why people are less comfortable, because it's not our wheelhouse.
Right.
And I'll put a link to a great video on it. I'll send you a link so you can put it on to the subgluteal. It's not too technically difficult.
Sure. Yeah. And if you could add the other videos on the ones we'll talk about here in a second too, that'd be great. So for those of you listening, there's a lot of links that Victor will be able to share. That the 5-minute tutorials are really, really good. So as far as the ACLs, they're in the brace. You're allowed to get the single shot. But once that wears off, I had my ACL done when I was in high school, and it was very painful. So what do you recommend for post-op care or post-op pain management? Similar to what we just talked about, is there a regimen of pills that you recommend?
Yeah, I mean, there's definitely the same, medication trio with the anti-inflammatory, the narcotic, the muscle relaxer, and then the gabapentin or the Lyrica.
Okay.
Obviously, for that, we do a lot of recommendation for the, ice, the polar cares and stuff like that. Unfortunately, insurance companies don't cover, these devices. So it becomes a challenge. It just becomes a challenge, it's definitely an out-of-pocket expense for the most part.
Sure.
I'm not, I don't try to generate any revenue off of these types of things that help the patient, but we also don't supply it. So.
Right. Okay. Anything below the knee? Are you doing ankles?
I do not do ankles.
Okay. So it stops there. Okay.
It's not, yeah. You found something I don't do.
There's something you don't do. Okay.
Yeah, exactly.
We found something. All right. Victor, did you want to show a couple of those images?
I'm happy to go over a couple of them. I mean, it's just in case people want to know what we're talking about, Yeah,
I think it'd be nice to show a couple of those images and maybe just walk through some of those simple blocks. And I don't do a lot of these iPACKs either myself either. So Christian, could you pull up those images on the left side, and we can just kind of go through a few of these images and kind of walk through there. So
sure. So first, if you can show just really quickly that. So here, this is just from the Nisora. Obviously, it's a really great resource online. You can see both sides of the knee with just the innervation. So you see on the left-hand side, you'll see the anterior portion of the knee. On the posterior side, you see this kind of like the posterior view. You're going to see essentially the popliteal plexus. Here they have it labeled out as like the tibial nerve, comperoneal. And that's the kind of the popliteal plexus. Now, could you please show me slide 2? Great. So here, So what you're going to be trying to do essentially is basically, is you see that little orange box there. What you're trying to do is kind of knock out, all the nerves of that popliteal plexus at the level just proximal to the two heads, just proximal essentially to the knee in that popliteal groove, and you essentially just put it. You put your probe right behind the knee. You're going to see the protuberances and that big groove. You move up just a little bit. You're going to see the popliteal nerve, and literally with the iPACK, I meant to say popliteal artery. What iPACK stands for is specifically is the interspace, and then you skip the interspace between the popliteal artery and the knee. So it's this kind of like right here, you're just going to kind of lay your local right along that thing. And so the best way to do it probably is to approach from the lateral aspect, and kind of go towards where you need to go to, and then just slowly on your way back, I think that the video does a really good job of mentioning this, and we'll link to it. But it's like you're filling up a donut with jelly. You just kind of like leave the local in that space, and it kind of knocks out that whole little plexus distal. And if you look at it, go back to slide number 3. If you look at the nerves we're trying to get there, and I've made allusions to this earlier, is like you see that they're a bunch of little nerves. You're not having to get this huge penetration. If you look up towards the top of that image on the left-hand side, you see a sciatic nerve. It's a honking nerve with fast, and things have to kind of take a little bit more to penetrate.
Yep.
But at that level, you're just knocking out these little branches, and you're trying to. The distribution is more important than the concentration per se.
How much volume? How much volume are you using in that last image where you?
So that'll be so typically you can put in anywhere about 15 mLs. I mean, somewhere between, depending on what you need. But it doesn't take a huge amount of volume. It just kind of, you just kind of put it in there, and you can use either 0.1 or 0.2 ropivacaine, depending on how you've negotiated with your surgeons. I was referring to before, but typically you can just put that in the back part of that knee.
Okay, yeah, that seems much more straightforward than I think it was presented to us many years ago. And I think, one of the things that kind of was like, oh, well, I'm not sure if I want to, pick up another nerve block, but it's not really quite a nerve block. It's more.
No, that's the thing. It's a misnomer. It's not really. It's really just, we're just dumping local in this. You're not trying to visualize individual nerves. You're just dumping local in this area.
Right.
Slide 2, please. Really just all you're doing is if you look at that slice on the MRI, slide 2, there you go. So if you look, you're not really, this is kind of obfuscate, little image over it kind of obfuscates it, but you're not really looking for anything. What you're looking for is you're looking for the popliteal artery, you're looking for that bone, and you're just kind of just dumping the local right there. You're not really trying to find any individual nerve. So it's really more of a field block, if anything, or, kind of an area block, but you're placing it in a very specific spot, and your goal is to knock out all those little fibers, for the iPACK.
Having watched that quick video, that 5-minute video, for the way that I do my, popliteal blocks for ankle procedures will be the same positioning, lateral with the operative side up. This seems pretty straightforward, much more than I think I had felt myself many years ago. So, for those of you listening, it's not a heavy task to kind of pick up this extra thing, which I believe, as Dr. Cohen's alluding to, it has a huge value. Yeah.
From you guys, for you guys that are older, at least me, I'm getting kind of, long of tooth. If you remember the femoral block, we would have to go and then do a saphenous or something to kind of knock out that, this is, this is the second block that you do. It's not, you do the femoral and the saphenous, and now what we do is we do the adductor canal, and then you go in and you do the iPACK to hit the posterior aspect of the knee, which is because what'll happen if you don't. And I'm sure that Brian can kind of confirm this, is that, if you take out all the nerves for the anterior portion of the knee and you control that pain really well, then that just makes the back of the knee hurt all that much more. They'll really complain about that quite a bit. And has that been your experience before that, Dr. Cohen?
Yeah, especially if we don't inject, if they don't have the iPACK and we don't inject intracapsular.
Yeah.
Then there's definitely a difference in the complaints, and it's mostly posterior.
How much are you injecting when you're at the other facility? How much are you actually injecting in the posterior
I mean, once again, it goes down to whatever the,
or the
to avoid
dots?
yeah, but it's usually about 15 to 20 cc's.
Okay. Okay. Which is not a lot really. So you can really accomplish a lot with seems like a little.
Exactly.
Yeah. Okay.
Yeah, and if I was going to try to save a little bit of local like volume, I think that the adductor is really where you can kind of get away with it depending on how you do it, right? The adductor canal.
Mm-hmm.
It depends. I mean, it depends. You know, you have to get it float, and it's not always predictable. You know how it can be where you're trying to put it in a particular spot, it doesn't go where you want it to go. You still put the local in, so you can't take it back. And so,
Yeah.
but the point is that you need it. But if you can get like a nice little float on the nerve,
Mm-hmm.
I would argue it doesn't. You don't gain all that much more by again, you want to use all the local you have. So
Mm-hmm.
if you don't use it and then the surgeon doesn't use it, it's kind of like, well, what did you do, right? But if you're doing it purposefully, thinking like I'm gonna like save just a little bit here, a couple of cc's here, a couple of cc's there of of 0.2, and now you have like 8 cc's of like 0.1 for somebody to go into the capsule with, for example, or do something else. That's, like I said, you have to work with your budget.
Mm-hmm.
But I think that's that these are all things that where the communication can be really, really useful, especially and in an ASC, when it's the same team over and over, or when it's similar people, you don't have to have this discussion every time. But I guess for our surgical colleagues that are listening or maybe watching, it's nice it's good to kind of just kind of get in that. Hey, we're going to discuss it. How much are you going to use? How much can you give me? This kind of thing. That's get into that habit, and you'll realize that pretty soon, like everybody kind of knows what everybody's doing, and you guys know what you can get away with. And then somebody says, "Hey, man, I had to use a little bit more. It kind of went in the wrong space," and everybody knows what but everybody's at least on the same page. It's super important. And the anesthesiologist should also participate and explain to the patient, as many people as can talk to the patient and say, like, this is not a pain-free procedure.
Yeah.
It's about making it tolerable so you can get up, get about, get back to your life. It's really important. That expectation setting is so important. That's one of the reasons that we can get away with using less narcotics, because we know this is going to hurt, and we have a very clear idea, right?
Yeah, that's one of my takeaways for myself tonight is that I think there's probably more of an intentional opportunity for us to talk to our block team or block nurses or pre-op nurses or packing nurses and really just drive home that message, which is this is not meant to be 0 out of 10. You are going to have some discomfort. Make sure you take these medications. Like Dr. Cohen said before, when this happens, go home and take it. Don't wait for it to hit you. We say that loosely to a lot of people, but we're not sure how adamant we are to take this.
And we should tell them that right after the surgery, they're going to feel great. Tell them, because they don't believe you. Say, oh, they said it was going to hurt, but I feel great. It's like, no. It's like right after surgery, you're going to feel like $1 million.
Yeah.
It's like, that is normal. That is the nerve block working. That is going to go away in a few hours. You want to get ahead of it. Take your medications that are scheduled as scheduled.
Right.
It's really important.
Yeah. I mean, like you said, the take home message is communication between the team and the patient, the team amongst the team. Everybody just needs to be on the same page. Yeah. And then a lot of these issues that come up that lead to hair pulling events would be less. So and I've been very fortunate to work with a lot of people that we can communicate and have these conversations, and it be more of, okay, how we're all here for the same thing. Let's get this patient out in a positive sensation, and with an education of what they can expect when they go home, and let's try to keep staying on top of this.
Mm-hmm. Brian, so you are heavily involved in not just clinical work, but non-clinical medical influence, and trajectories of where orthopedics is going in the future. Do you see any major changes in orthopedic care, related or not related to regional anesthesia, but for you in the next several years?
I mean, going back to Victor's point, I think we're just going to get, the medications are going to get better.
Yeah.
With like Exparel is an example of one medication that has a longer lasting half-life. I just think that's where we're going to see it. And as I can tell you that 10 years ago nobody was using an ultrasound for a block. Mm-hmm. Now nobody will not do a block without an ultrasound.
Right.
So it's what's that next technology that's going to I don't know how, AR and VR are in the anesthesia world. Obviously in orthopedics, it's a big thing. augmented reality and this virtual reality, and what are we wearing, these, Google Glass or some other headset. So I don't know if there'll be something like that in anesthesia that'll just help you see where you need to go without having to use an ultrasound.
How about in the sort of robotics? So do you do yours with the Mako?
Yeah, I do the Mako, correct.
Okay. So let's say the next iteration of what's the next iteration of that technology?
It'll be some type of augmented reality where you're able to register the patient, which is basically what we do to kind of where is the knee or the hip in space related to the robot.
Right.
So we'll be able to register without this line of sight that we require now.
Without having to do those 50 points where you're
correct. Yeah. So now it's a camera that the sensor has to see. In the future, it'll be, we could just see it based off of the preoperative plan and what we do to get the patient situated, positioned. So the thing I like about robotics is really that at least for the knee, the cut is so accurate. And it really allows the implant to fit, and if I want to change something, I just program the computer. If I want to change something a degree or cut an extra millimeter, manually we have to either eyeball it and adjust it, or we have to move the cutting block down a millimeter, which who knows if it's a millimeter, it says on the block, but
Right.
robotically it seems to be, it's more accurate. So I like the accuracy that comes with robotic.
Yeah.
And also the plan, I tell my patients, everything we're doing specifically for the knee we're working on. It could be a different plan for your other knee. And so we're doing a plan specific for the knee we're working on. And we almost do the operation first on the computer before we do it on the patient, so that we know what we're trying to accomplish and how to get there. So
that's interesting. I mean, I thought the Mako in general was a huge innovation. I mean, to know the topography of the knee, much like we see for the spine. I mean, we do a CT for the spine. We know exactly where every little tiny bump is on the spinous process for spine surgery, and now we see that for the total knees and for the hips, really.
Correct.
And so, do you see anything like that for sports potentially?
There's some companies out there that are looking at AI to identify different structures. There's a company out there called Caliber, and they basically, when you put the camera in with their technology, if you're in a knee and you're looking at the ACL, it'll come up, this is the ACL. You're looking at the meniscus, there's a meniscus, so, and then how do you use that technology so that now when you have a tear, you may have, okay, these are 3 different ways you could accomplish this repair, so it's that visual recognition.
Sure.
That the AI is identifying and explaining how to fix.
Yeah, I mean,
based off of everything.
You see the same thing in the ultrasounds, right, Ankit?
Yeah.
You see the same thing in ultrasound where like the AI is like identifying all the structures for you. So it makes it a lot easier. I have, from an educational standpoint, I have my qualms with it, for residents, but it's definitely a really useful tool out in the world, right?
Oh yeah, I mean, AI is going to change the way most modern healthcare is going to be done very soon.
The other thing that I'm going to say is that, as moving forward, is we're going to be looking at like this, kind of local spare, because as we start seeing like, oh, we can hit, like, instead of hitting just this nerve, we're going to hit all these other ones and kind of like knock them out. Is that sparing portion of it? Like, how much can you get away with like giving less of, so you can have more to give somewhere else?
Sure.
I think that's going to become a more active area of research as well.
Oh yeah, I think so. Okay. Well, we're getting up on the hour. I don't see any questions on the chat chain, but Brian, any last comments, questions, concerns? I mean, I think this was a great conversation. We really appreciate your insight. This is your field.
I really appreciate you guys having me on. Like I said, I think communication between the fields is really important. It's nice to talk amongst other orthopedic surgeons about what we're doing, but it's nice to also cross-pollinate and make sure that we're all on the same page and we're all going in the same direction, because the goal is patient care. So, and if we're not communicating, we're not going to do a good job.
Exactly. All right. Well, Victor, as always, thank you. And we've got part 2 coming. Hopefully, the same team will be available to do our upper extremity regional anesthesia in a few weeks, and then we'll keep on moving. Thanks, Victor. Dr. Cohen, thank you so much, and we'll see you soon. Thanks, everyone, for listening in.